Okay, class. So we are going to talk about basic fetal monitoring. This gives us a little bit more of an in-depth idea about basic fetal monitoring. I know for some of you, you really need to be able to dive into it and understand it, and it's a little more detailed than we're able to go over in class. So I figured this might supplement your information a little more. So the maternal fetal oxygen pathway is really what we're going to concentrate on, and how everything that affects mom affects baby, and what we're really talking about when we talk about that. How we assess baby's fetal heart rate and uterine assessment, our interpretation of the fetal heart rate, and then our interventions to fix any issues that we see with the fetal heart rate that causes concern. So the maternal fetal oxygen pathway is a really important concept to understand. Along this pathway, you have everything that could affect it: the lungs, heart, vasculature, uterus, placenta, and umbilical cord. So we're going to break it out to look at the maternal aspect, and then the uterus, placenta aspect, and umbilical cord and baby. So maternal factors. Forgive my slide, it's a little bit wonky right there, but the lungs, heart, and vasculature are really a critical thing. If anything's wrong with mom and mom's lungs, mom's heart, it's going to be wrong with baby, okay? Mom is the only source for baby's oxygen. Baby's fetal oxygenation is completely dependent upon mom. So when we look at this, we have to look at, first of all, I took out some of the slides about the maternal adaptations of pregnancy, but all of those are very, very important. It is critical to understand that perfusion, mom's perfusion and mom's oxygenation, tying it back to the concepts, oxygenation and perfusion of the of mom is important for baby. So if anything is bothering mom's oxygenation or perfusion, that's going to affect baby. So that's one of the reasons why we have those adaptations of pregnancy, like the 1,200 to 1,500 mLs of extra fluid they now have, the increased heart rate, the decreased systemic vascular resistance. All of those factors really play into getting the optimal perfusion to baby. Okay, so when you look at the uterus, one thing that's really interesting about the uterus, and I wanted to keep this slide in there so you guys could really see it, is that you have these spiral arteries. So these spiral arteries, they're super neat. When you have a contraction and you have that uterus contract, those spiral arteries are able to contract with the uterus and still have some blood flow. So it's an adaptation of our uterus that makes it a little bit special, a little special organ, to where even whenever it's contracting, they can still have blood flow. Okay. So when I talk about that, I want you guys to think, okay, if there's anything going on with that uterus, if there's anything going on with those really, really strong contractions, say we're having a whole lot of contractions, that's going to affect our blood flow. Okay. Maternal positioning. So we've already talked about this. I know it's super important. Never have a mom flat on her back, right? Because we are going to cut off that vena cava that's going to give us that cardiac preload. We're cutting off our aorta. We're going to have symptoms from mom like, diaphoretic. She's going to be lightheaded. She might be dizzy, that kind of stuff. Might be nauseous, because anytime that we're not, our brains are not getting perfused, we're going to get a little bit nauseous. And then in addition to that, we also will see effects with baby, and we'll talk about that too. So super important, maternal positioning. Now the placenta. So when we talk about the placenta, we've talked about how the placenta works as this amazing organ that is able to supply oxygen to baby and take out the CO2 from baby. It's really, really cool how it works. It is, like I said, the primary source. So you have one part of the placenta. The placenta is attached to the uterine wall. And on this side, you have baby's blood, right? The fetal blood. And on this side, you have the maternal blood. And they don't actually mix. Super neat. In that little space, you've got those spiral arteries. Those spiral arteries are basically giving that oxygen-rich blood in that little space. We call it in the intervillous space, right? So the space in between the placenta and the uterus, okay? And in that space, you have this pool of maternal blood. All of the spiral arteries are just pouring that blood into that space. And then you have all the little fetal capillaries. I like to call them fingers, little fetal capillaries that are up there trying to get that blood. And what they're doing is they're going over this, I'm going to get to it. There we go. They're going over this membrane, right? And so passive diffusion, when you diffuse, you go over a membrane. They're going over this membrane, and those little fetal capillaries, they have a higher oxygen affinity, higher O2 affinity than mom's blood. So the fetal capillaries are like, give me the blood. And then the mom's blood is able to cross over because you go from a higher concentration to a lower concentration. Fetal blood is always a little bit more, a lower oxygen concentration than maternal side. So you're going from that higher concentration to a lower concentration. And in addition to that, the fetal oxygen, like I said, they have the higher affinities. They're actually able to carry more O2 on a fetal hemoglobin than maternal hemoglobin. So looking at the umbilical cord, this is another piece that can definitely affect our perfusion to baby, right? So once they go through those fetal capillaries, they're able to go through the umbilical cord and carry that blood to baby. Remember, you have 3 vessels in the umbilical cord. You have the vein and you have the 2 arteries. I always remember as AVA, right? It's A-V-A. And then our vein is actually bringing that oxygenated blood to baby, which is super cool. You can see how it's got that jelly around it. We call that Wharton's jelly, and it helps protect our umbilical cord. If this is the primary perfusion to baby, you can imagine why it needs to be protected, right? So, like I said, the umbilical vein carries that oxygenated blood. The arteries carry the unoxygenated blood. So they carry away the oxygen blood away from baby. So it's a little opposite than what we think of, but it's because it's based upon mom's system and not baby's system. Okay. So our arteries are carrying the waste products away, and that's where we're able to get rid of that CO2 in that same intervillous space. So think about if you have this umbilical vein that's super, super, super important, what would be concerning if that was compressed, right? If it's not getting that optimal blood flow that's going to affect our baby. And so ultimately our baby is also a factor. So if anything is wrong with our baby, we may not have a well oxygenated baby. So really what we're looking at when we look at the fetal heart rate and how it can affect baby, we're looking at the perfusion of mom and mom's oxygenation status as well, but oxygenation and perfusion of mom, and that affects specifically our oxygenation, or a fetal reserve of baby is another term that we use. So our fetal circulation is super important in all this, and this is where it tells you about the fetal hemoglobin that has that higher affinity for O2 than adult hemoglobin. So their concentration values, they're higher at term, they're able to carry more O2, okay? And so honestly, the fetus does live in a comparatively oxygen poor environment, right? They're inside, they're not breathing, their lungs are not working, it's a completely different type of system. So their SpO2 is usually around 30 to 35. You won't see us doing an SpO2 of a fetus anymore right now in current practice, especially in the United States. So you might see it in places, but not here. And this just kind of reviews our fetal circulation, which I know we have already talked about, and we're going to talk about more. I'm not going to get into detail just yet. The amniotic fluid, just another review. Amniotic fluid is very, very important. So if you have low amniotic fluid and your cord is not able to just float in its wonderful environment and get that great perfusion, then we also would have a compromised baby. Okay, when I say compromised baby, I want you guys to think about a low fetal oxygenation or a low fetal reserve. Like I said, is another word that we'll use for it. Okay. Okay, so yeah, looking at our amniotic fluid, you can see how it can be important. It talks about the normal, oligohydramnios, too little fluid, polyhydramnios, too much fluid. So when you have too little fluid, you don't have that umbilical cord floating in that wonderful environment where it's not able, it's not getting compressed, and you're able to get the optimal perfusion. When you have too much fluid, you could also have a cord that gets tangled, whether it's wrapped around the baby's neck or gets a knot in it or something along those lines, so that can affect baby as well. And then it's just a little reminder about how fetal urine is what makes up most of amniotic fluid. So if you guys didn't know that, now you do. So if we were concerned about low amniotic fluid, what organ of the baby would we be concerned about? We'd be concerned about their kidneys, okay? So when we have low amniotic fluid, that's one that's telling us, one, is something wrong with their kidneys. Two, is there anything wrong with baby not getting the optimal perfusion? So perfusion to baby from mom, and then with baby, if baby has low perfusion, low oxygenation, the body knows what it's doing and it's going to shunt it to the most important organs in the body. And unfortunately, our kidneys don't always make the cut. So when we see that, it's telling us that the baby is not in the best environment, okay? Baby's not getting the best perfusion. So looking at the blood flow and the uterine activity, when we're talking about, like I said, the uterus is also very, very important. So if we have anything that's disturbing that blood flow to the uterus, that's going to affect our baby. Now, sometimes fetal reserve, so what fetal reserve really is baby basically have enough oxygenation, enough fetal reserve to withstand stress. So here's the thing. We talked about contractions. We talked about those spiral arteries. What happens with a contraction is it actually cuts off blood flow to baby. So a really strong contraction, you actually have no blood flow to baby. So when that happens, if a baby is already compromised, has already been living in a struggling environment, they're not going to have enough fetal reserve to withstand that stress, okay? So, like I said, when the uterus is at rest, the blood is able to flow freely into that space. They have optimal perfusion. But when you're at the peak of a contraction, baby is not able to get any blood flow. So think about it. If you are truly exhausted, say you just ran like a 15K or something like that, and then somebody asks you to hold your breath, it's going to be a lot harder for you to hold your breath for a long time than it would be if you were completely at rest. So think about just the baby being under this stressful environment, and then now is the baby able to withstand the stress. So if anything's a problem along that pathway, we have that baby. So a very unhappy baby. So what are some examples of problems along the pathway? So we talk about, the mom's heart, lungs, vasculature, all of that being really, really important. So anything that could impair mom's heart. So if she has an arrhythmia, if she has reduced preload, which could also be caused by hypovolemia, or in compression of the inferior vena cava. It's like ringing a bell. So supine hypotension could definitely cause a problem along our oxygen pathway, specifically with mom's heart. If she has hypovolemia, so if she has very little fluid intravascularly, right, it could cause a problem with her preload, okay? So if she's dehydrated, anything along those lines, like dehydrated, if she has low blood pressure for other reasons, it could cause that reduced preload. If she's got impaired contractility, so if she's got diabetes, cardiomyopathy, CHF, anything along those lines, And then if she has increased afterload, so our hypertensive patients also are going to have a problem with their heart, maternal heart, that's going to cause a problem along our maternal oxygen pathway. So along the same lines, if she's had anything within the vasculature, so really we're talking about hypotension. And here's the thing. One of the main interventions that we do in labor and delivery actually causes hypotension. So when we do an epidural, it causes that systemic vascular resistance to decrease, which means their blood vessels vasodilate, right? And when that happens, that's going to drop their blood pressure. So what we typically will do before we do an epidural is we're going to give them IV fluids. We're going to give them a fluid bolus. Honestly, a lot of the research shows to give it a third of it before you start the epidural, a third of it during the epidural, and a third of it after the epidural for the most effective way of giving them fluids. But the big key takeaway is that it can drop their blood pressure, okay? And when it drops their blood pressure, that is going to affect our fetal oxygen pathway. So our pathway of perfusion to baby is now affected. Other things, like I said, hypertension especially can affect it. Preeclampsia is, we'll talk more about that, but it's definitely a condition that can affect our blood flow to baby. And then uterine contractions. So just having contractions. Remember I said really strong contractions. At the peak of the contraction, there's no blood flow to baby. No blood flow. And there's like a chart that you can see that shows you what you had optimal blood flow to baby. I want to say it's like, depends on the strength of the contraction, but you have optimal blood flow to baby. You have reduced blood flow to baby as the contraction is starting to go up. You get up to the peak, you have no blood flow to baby, and then it comes back down. So sometimes we say in labor and delivery, like maybe just hold your breath and then you'll see what the baby's feeling like. So it kind of it gives you a picture of why it's so important for us to, if we're doing something like giving oxytocin, which we'll talk more about, but giving oxytocin to bring on contractions, why it's so important for us to watch and manage that oxytocin and make sure that our contractions are not hurting our baby, okay? And then anything that can affect the uterus, like uterine rupture or trauma to the uterus, obviously could affect our baby as well. So looking at the placenta, anything that's wrong with the placenta can also affect baby. So if you have a placenta abruption where the placenta is no longer attached to the uterine wall, that can affect baby. If you have a placenta previa where your placenta is lying over the internal os of the cervix, that can affect baby. If you have a vasa previa where our arteries and veins are attached to that fetal membranes instead of the placenta, that can affect baby. Okay, so anything that's affecting our placenta can definitely affect our baby's fetal reserve. Okay. Okay. So looking at the umbilical cord, like I said, umbilical cord can also affect our baby. If we have any issues with compression in the umbilical cord, if we don't have the umbilical cord in that optimal environment, it can definitely affect it. So anything along that pathway is going to affect our baby, okay? This just goes over Leopold's maneuver. So Leopold's maneuver is a method to figure out the lie of baby. Like, do you have a baby that's head down? Do you have a baby that is breech? Where are you optimally going to be able to find that fetal heart rate is really kind of what you're doing. And the way to do it goes through all of the steps. You get better at it with time. So it's not a skill that you're necessarily going to be an expert at, okay? We don't really even do Leopold's maneuver until you get into intermediate fetal monitoring. So this just shows you a typical fetal monitor that you'll see in a lot of the hospitals. And The most common type of fetal monitoring that you'll see is this electronic fetal monitoring. So you have an ultrasound and a toco. Okay, so the ultrasound is what's going to record baby's heart rate, and the toco is what's going to record the contractions, whether she's having a contraction or not. This also shows you wireless monitoring. So this is another option. I'm not sure which hospitals have it. I know we had it at my old hospital, but it was created actually for obese patients because it made it easier to monitor them. It actually works better with an obese patient versus a patient that is just all baby, all belly. So it has to be used for a singleton pregnancy, and it's not recommended for preterm still. I'm sure more research is probably being done, but right now it's only for full term and only for a singleton pregnancy. And it is really neat. They can walk around, they can move around. Does have restrictions as depending on the Wi-Fi, because that's what it goes off Bluetooth. This is the internal fetal monitors. So we have internal monitors. They are considered invasive. Their membranes have to be broken for this to be placed. So they would have to be at least somewhat dilated for it to even be placed. There is some evidence that can show the fetal scalp electrode is, that's the FSC. That's the one, it goes on top of the baby's head. It just goes right, really just breaks the layer of skin. So that's one of the reasons why we also consider it invasive. So it increases baby's risk of developing an infection because it's just broken the skin barrier. That being said, it does not actually harm baby's head. You wouldn't want to put it over a course of fontanelle or anything along those lines, but it does not harm baby's head. It actually goes on the presenting part. So if your presenting part is a buttocks, it would go on that too. The IUPC, the intrauterine pressure catheter, measures the intensity of the contraction. So the toco, people sometimes think that tocos really measure how strong a contraction is. That's not true. It does not. It only measures that you're having a contraction. If for some reason we need to have more information, say we're concerned that the contractions are too strong, or we're concerned that the contractions are not strong enough, that's most typical, we might place an IUPC. Again, it is invasive. Their water has to be broken. There are risks with the IUPC, and just about any time that we're introducing something from an outside environment on the inside, we're increasing her risk for infection. So let's kind of go over what we see with the fetal monitor. So if you look at this, it talks about how each bold line is 60 seconds, and then each little line is 10 seconds. So if you look at it, I know it's a little bit harder to see, but the bold, big fat bold lines are 60 seconds. And then the smaller lines might be really hard to see. I can't see it from your screen. I know on my screen it's super tiny, so it's harder. But they are 10 seconds, okay? So the big bold lines, kind of remember that as your minute, right? And then if you look at it, you can see how the heart rate is the top part, how the heart rate goes up incrementally. So you have to be able to see the numbers. Of course, we know our baseline's 110 to 160, right? So what you'll actually see is that usually like 120 and 150 is what you'll see, but we know what our baseline is. And then the bottom part is going to be looking at the contractions, okay? And so remember, you can only see the intensity of the contraction if you have that internal monitor, that intrauterine pressure catheter, the IUPC. With a toco, we just see that they have them, that's good too. So ideally, we're looking at contractions to see, are they doing what they're supposed to do? And this is kind of a review, I know, but we're looking at, are they dilating her cervix? Is she effacing? That kind of stuff. What's important to remember, the toco, I already said, it doesn't measure how strong the contraction is. So what's the only way that we can really tell if the contraction is strong or not? With our hands. So obstetric nurses know this. When you go into a patient's room and you're doing a head-to-toe assessment, and they're having contractions, we palpate their fundus, right, the top of the uterus, during a contraction. If we are going up on our Pitocin, we palpate the fundus during a contraction. Okay, it's super important that we are assessing what we are causing, right? Assessing what we are causing. So other things that we look at when we look at our uterine activities, we want to know the frequency. So from the beginning of one contraction to the beginning of the next contraction, that's our frequency. Usually you go to the smallest one and the biggest one. When we do a fetal monitoring assessment, we usually do it for a 10-minute period. So we have like a 10-minute strip, and we're looking at, okay, this contraction is really close, this contraction is really far. That's what our frequency is, 2 to 4 minutes, right? Duration, we're looking at the beginning of the contraction to the end of the contraction. So how long is the contraction lasting? And then intensity, like I said, IUPC is the only way we can actually measure it on the monitor. Really the best way for us to tell intensity of the contraction and resting tone is with our hands. So even if we have an IUPC on, we still put our hands on their belly, okay? Hands-on assessments. So it's super important to do that palpation. And I'm not going to jump ahead. I'm going to wait until I get to it. When we're doing the palpation, like I said, we want to make sure we're doing it at the top of the fundus. Now, sometimes you may not feel the contraction best there, so you have to move around a little bit, especially with a mom, like an obese patient, might be a little bit harder. So we have to find the optimal place that we're feeling the contractions, especially if they're early on. So, remember that fundus continues to rise throughout the pregnancy. So if you have somebody that's a 24-weeker, especially when the fundus is near the umbilicus, it's actually very difficult to measure it on our monitors and sometimes even with our hands that way. So you have to feel their belly and find the best place to feel the contraction. So when you're palpating, this is what I didn't want to jump ahead about. When you're palpating, we always use this. I think almost every OB nurse knows this one. So a mild contraction is the tip of our nose, moderate is our chin, and strong contractions are our forehead. So I know you guys are watching from home, but do it with me: mild, moderate, strong. Okay. We talked about how the TOCO doesn't really measure how strong, but it does get frequency and duration as long as it's placed properly. Of course, all monitors can be wrong. So it's just a little review about how the fundal height is. We don't want to ever place it over the umbilicus. It just does not measure correctly. It has to be, this is why TOCOs can be a little tricky. They are a flat monitor and they go on a round belly. So that makes it a little bit harder. So you have to kind of play. So this is just a picture of our intrauterine pressure catheter. Remember, this is the internal monitor that we use to be able to measure the strength of the contractions, okay? With this, of course, it is invasive, like I was saying. We would only do it if we really needed to see how strong those contractions are. Sometimes we might do it if we are trying to see, like, what kind of, we need to be able to have a really good read of the contractions. If we wanted to do things like an amnio infusion, we would need to have an IUPC in place, okay? So resting tone, again, something else that we're putting our hands in the belly for. So in between the contractions, that's what we're talking about with resting tone. Resting tone should be under 20, okay? So the measurement of it should be under 20, and that is because of that perfusion to baby. If it's higher than that, you're risking having reduced blood flow and then ultimately cutting off blood flow when it gets too high. So like I said, from the beginning of one contraction to the beginning of the next. So you can see this one would be documented as 2 to 4 minutes. You take the shortest and the longest. So when we're talking about tachysystole, we're talking about having greater than 5 contractions in 10 minutes, average over 30 minutes. When we have tachysystole, We first really, I'm going to skip ahead a little bit. It says may be corrected by, so that's really our first intervention, is decreasing or stopping oxytocin if we're causing the contractions. Another option might be one of the tocolytics, but the most typical one you'll see is what's mentioned there, terbutaline is the one you'll most likely see. And then the other parts that we might do, especially if we start to see effects to baby, are those intrauterine resuscitation. So maternal positioning her on her side, right? Right or left lateral are our most typical first interventions. Giving her a fluid bolus, so that might also be something that we would do to correct it, or giving her O2 with a non-rebreather. So usually 10 liters O2 with a non-rebreather is what you'll most typically see. So like I said, when we're talking about our duration, we want to go from the beginning of the contraction to the end of the contraction. If we have a really long contraction, we're cutting off blood flow to baby for even longer, so that can definitely affect our fetal oxygenation. And then our intensity, what was the one that we can't use for intensity? So we can't use a toco, right? So we can use the IUPC. We can also palpate with our hands. And that is the best way for us to be able to tell the intensity of the contractions. And so again, if they're really, really strong contractions, that could be potentially cutting off our blood flow to baby. We want optimal resting time. So usually they say about 1 minute during the first stage of labor and 45 seconds during the second stage of labor. And the reason is because the contractions are cutting off blood flow. So if we have that good resting tone in between, baby's able to catch a breath. So, if you're sitting there holding your breath, you want to have enough time to go, oh, okay, I can breathe again. Okay, now I'm ready. And then hold the breath again. So you want to give baby enough time to get catch their breath, get a little rest. Like I said, IUPC is what we use, the intrauterine pressure catheter is what we use to measure Montevideo units. Now, Montevideo units, you guys don't need to know how to count these at all, but they're basically what we do to measure the strength of the contraction. This just shows you the measurement of Montevideo units. You can actually see it. I can even see it, so you guys can definitely see it. You can see how high it rises. So it looks like it's 75. So when we are actually calculating it, what we do, and I think the book goes into the detail about this too, you take 10 minutes and you count up from the baseline. So from that resting tone, you count to the top of the contraction. You would count all of the contractions. So when they're talking about like optimal is between 200 and 300, that kind of thing, that's how they're measuring it. So they're measuring it in that 10-minute period and from the resting tone up, and then just adding them all together. So this actually shows you, I love this slide, it's like one of my favorites. It shows you what we mean when we say it cuts off blood flow. So you can see you have optimal blood flow down at that resting tone in those contractions, reduced blood flow, and then absolutely no blood flow to the uterus. So this is why it's really important when we are doing things to give them contractions that we need to be managing it and be on the top of our game, that we are not cutting off blood flow to baby. Okay, so this just goes back over our methods that we could use for a fetal heart rate assessment. So we might use a Doppler. It's a little handheld machine that we're able to use to hear the baby's heart rate. You probably aren't going to see a fetoscope anytime soon, but that's that little stethoscope that they put on their head that's super interesting looking. And then the external ultrasound, and then of course we have our internal fetal scalp electrode. And we also have the Wi-Fi, the wireless monitoring, right? So one thing that's really important for us to know when we are assessing baby's heart rate is that we also need to know what mom's heart rate is. It is actually easier than you would think to get those mixed up. So it's really important to know what mom's heart rate is when we're looking at baby's heart rate. When we look at baby's heart rate, kind of one of the best ways to look at the heart rate is first, Identify what the baseline heart rate is. What is the baseline fetal heart rate? Second, look at the variability of the heart rate. What is the variability of the heart rate? And you guys will understand this more in a little bit. Third, accelerations. So our accelerations indicate fetal movement. They are positive, they are good. So we want to see accelerations. Fourth, decelerations. So do we see any drops in the baby's heart rate? Okay. Decelerations generally are considered bad with the exception of one. And then what are the changes over time? Ultimately, what does our whole strip look like? So when we're looking at our baseline fetal heart rate, it's between 110 and 160. That's our normal baseline. Well, you may have a under 32 weeker, it might be slightly higher. It should still be between 110 and 160. When we look at it, we're looking for 2 minutes. So say we have a 10-minute strip. We want 2 minutes of the same on that strip. So we try to find where is the line that the fetal heart rate mostly lies on. Okay? Does not need to be contiguous. It does not need to be continuously on the same line. You can have jumps, you can have accelerations in the middle of that. You can have decelerations in the middle of that, and it does not affect it. So where's the majority of the fetal heart rate? You have to have it, so like I said, at least 2 minutes, and then it can't change for more than 10 minutes. So say I have my fetal heart rate's 120, and then I have an acceleration, and I'm like, oh, that's cool. They did an acceleration. That's awesome. And I'm watching it, and it's like 150, and it continues, and it's still 150. 5 minutes later, 6 minutes later. So once it gets to 10 minutes, it's actually now changed. Our baseline fetal heart rate has changed. Okay, so this is going over deviations from the baseline. So tachycardia, things that could cause tachycardia are things like maternal fever, infection, medication. So, if she does have chorioamnitis or intrapartum intraamniotic infection, you could see fetal tachycardia in the baby, just like you could see tachycardia in the mom as well. So medications, so anything that speeds her up can definitely speed up baby. Medications like terbutaline, actually, what we give in labor, if we are trying to slow down or stop those contractions, can definitely cause mom's heart rate to raise and will cause baby's heart rate to raise as well. Caffeine. Like I said, anything that speeds her up will speed up baby. Fetal anemia. So you know how if a adult patient is anemic, you'll see tachycardia is one of the main causes. It's the same thing for a baby. So you would see fetal anemia, maternal hyperthyroidism, and fetal cardiac arrhythmias. For bradycardia, this is again, these are both if they last longer than 10 minutes. The interruption of the fetal oxygen pathway is kind of one of our first things that we're thinking about, especially if it's significant bradycardia. But really, we're trying to figure out the cause. That's always the best thing. We want to know the cause so that way we can actually treat it. Maternal hypoglycemia, maternal hypothermia, anything that slows down mom is going to slow down baby. So if we're giving her something for pain, like fentanyl, morphine, Stadol, those are some medications that you may have heard of. Butorphanol, I think it's called. Those are medications that we might give for pain control. If it slows down mom, it's going to slow down baby. If we give diphenhydramine, if we give promethazine, medications that slow us down, it's going to slow down baby as well. And then cardiac conduction abnormalities, viral infections like cytomegalovirus, and fetal heart failure are some other reasons that you might see it. Okay, so this is a baseline practice. It's a little bit harder for me because it's really hard to see the strip on my little presenter screen here, but it looks like our baseline is about 145. So you can see most of our fetal heart rate is on the 145 line. Now, we don't really get to, so if you were in class with me and we were doing this, we don't really get too specific about you know, if you said 150 and I said 145, you're not gonna argue that in court, okay? You're not gonna argue 5 beats in court. So as long as you're within 5 beats, it's usually considered accurate. So again, baseline practice. This is really hard for me to see. I want to say it might be 150, but I cannot see it very well on my screen. So you want to see where the majority of the line falls. So that's the first step. That's the very first thing that we look at is baseline. Our fetal heart rate variability. So when we're looking at fetal heart rate variability, we want to look at the fluctuations of the baseline fetal heart rate. So it does not include accelerations or decelerations into the mix. We take those out when we're trying to figure out what our baseline is. Okay? So we look at our baseline and then we see the variation. So a baby's heart rate is totally normal for their heart rate to go up and down, up and down, up and down. It's a little less normal for ours. We don't typically see it in the adult population the way we see it in babies. But it is very normal for a baby's heart rate to do that, okay? So what we have 4 different types of variability that we talk about: absent, minimal, moderate, and marked. And we're about to look at a picture of them, but we need to have that definition in our head. So our absent is going to be a complete, just straight line, pretty much. It has no variation. I've heard some people refer to it as teeth. It has no teeth. It has no variation. Our minimal, we have a little tiny bit of variation, but it's less than 5 beats. Okay? 5 beats or less, I should say. Moderate, it's greater than 5 beats, so it's 6 to 25. So moderate is our optimal. I'll just go ahead and put that out there. Moderates are optimal, and it's between 6 and 25. And then marked is greater than 25. So you can see the little picture. Our absent is just our very flat line. Our minimal, we see a little bit of variation. Our moderate, we see that 6 to 25, greater than 5, 6 to 25. And then our marked, it's all over the place. So if you're looking at a fetal heart rate and you can't figure out what the baseline is, probably means that you have a marked, okay? So doing our variability, we would want to see, like I said, the moment-to-moment changes in that fetal heart rate. So the reason why variability is really important, just know that, really important. Moderate variability is a reliable predictor of the absence of fetal metabolic acidemia at the time that it's observed. So one thing about fetal monitoring does not give us a whole lot of information. So you would think that it was correlated with these amazing like fetal outcomes, neonatal outcomes, but it's not. But moderate variability is a good predictor. At the very least, it predicts that we do not have fetal acidemia. So that's good. When we have minimal or absent variability, it doesn't say that they're acidemic. It doesn't say that they have fetal acidemia, but it doesn't rule it out. Okay? So when we have this minimal or absent variability, it puts them in a different category. So things that can cause that, if babies sleep just like we do, and when they sleep just like we do, their heart rate is going to have less variation. So that's normal. That's normal. So we usually give them about a 20-minute sleep cycle, and then we're like, okay, baby, we want you to wake up now. Okay. Fetal tachycardia. So if their heart rate is really high, if it's greater than 160, right, that's fetal tachycardia. If their heart rate is high, you'll have less variation. Medications. If something's chilling mom out, it's going to chill out baby too. So if we're giving her something like diphenhydramine, if we're giving her morphine, if we're giving her fentanyl, if we're giving her Phenergan, you know, something along those lines, promethazine, sorry, something along those lines, then it is going to chill out baby just like it does mom. If we have a really premature baby, if we have congenital anomalies, fetal anemia, that kind of stuff, infection, anything that's affecting mom and baby, you're going to see it, and you'll see it with the lack of moderate variability. Okay, y'all, so I switched so I can actually see it on a much bigger screen now. So for the variability, for the first thing I want you guys to do is your baseline. So always do your baseline first. And this baseline looks like it's about 140. And then our variability, overall, I would call this moderate variability. Okay, so you want to look at it as the whole entire picture. If you were looking at one single minute, there might be 1 minute where you're like, well, that's minimal. But overall, you're looking at the whole picture, and this would be a moderate variability slide. Okay, so for this one, again, do your baseline first. So your baseline, you're looking at about 150. It starts out 155 and looks like 150 at the end. I would say overall we could call it 150, but you would be right if you said 155 or 150. Okay, and then for your variability, so this one's a little harder. Overall, it is minimal. It's minimal variability, but there's definitely some smoothness to the line. So I would not want to see how that strip looks at the very beginning. I would not want to see that continue. That would be concerning. Our absent variability is considered our most abnormal variability. One of our, well, marked is too, but one of our most concerning, and we'll talk about why that is in a little bit. Okay, so we look at whether our accelerations, yeah, a little bit, but more decelerations and how they're associated with contractions. So that's the first piece that we look at. So periodic are decelerations that are associated with contractions. And think of it like I have my period, I have pain, contractions have pain. That's the way I remember it. Episodic, not associated with contractions. The other piece that we look at is whether it's recurrent or intermittent. So if it's recurrent, it's going to occur with greater than 50% of contractions in 20 minutes. Intermittent is going to be less than 50% of contractions in 20 minutes. Accelerations. So accelerations are when we have the fetal heart rate jump 15 beats per minute for 15 seconds over the baseline. So you have your baseline, it's like 125, 125, and then it goes, and it goes up to 140, okay? It does not have to do it for the whole entire 15 seconds. Like, it does not have to be up to 140 for the whole 15 seconds, but that jump has to last for 15 seconds, okay? So if they're greater than 32 weeks, that's how we count accelerations. If they're less than 32 weeks, 32 weeks is kind of our line. We do 10 by 10s. So it's for 10 seconds and 10 beats per minute. So 10 by 10 for less than 32 weeks. And then greater than 32 weeks, you're doing 15 by 15, okay? Now, if your acceleration lasts longer than 2 minutes, it's not just a normal acceleration now, it's prolonged. It's prolonged acceleration. It doesn't really mean anything. What it does mean, though, is now I'm watching that acceleration, because when will it become a new baseline? Once it goes over 10 minutes. So if you have it over a 10-minute period, then it becomes a completely new baseline. So for acceleration practice, let's do our baseline first. So our baseline looks like it's about 135. We have moderate variability, so we always do variability next, and then we do have accelerations. And I'm pretty sure this slide is not going to line up with its little circles. So, yep, actually it did. Okay, we might have some in the future though. Okay, so decelerations. So we have 4 different types of decelerations, but 3 are really the ones the way you're going to focus on it, because you're going to pick up that prolonged real fast. So we have early, late, variable, and prolonged. Okay. A term that you'll hear me say is nadir. So it's the lowest point of the deceleration. Okay, it's a good one to remember. So with a deceleration. An early deceleration is from the onset to the nadir, so from the beginning of the decel to the lowest point of the decel is greater than 30 seconds. Okay, it's important to know because it helps you determine between your different types of decels. Okay, it mirrors the contraction. Now, I will tell you, like, their bodies don't read our textbooks, so it may not look absolutely positively identical, but the peak of the contraction should line up with the nadir of the decel. So what happens with early deceleration? And this slide looks a little wonky. What happens is you have that fetal head compression, which alters our intracranial pressure and our cerebral blood flow. So you have that sympathetic reaction, okay? And when you have a sympathetic reaction, it decreases our fetal heart rate. And that's what causes our early deceleration. Interestingly, it's only caused by head compression. So that's one of the reasons why early decelerations are not the concerning types of decelerations, okay? Late decelerations. So a late deceleration is where you have a gradual decrease from the onset to the nadir is greater than 30 seconds, okay? Or equal to, greater than equal to, you see it on the slide. And it actually occurs, the nadir occurs after the peak of the contraction, okay? So you see on these, the nadir, the lowest point of that decel is after the peak of the contraction. So what happens with a late deceleration? Late deceleration is caused by uteroplacental insufficiency. Another way, and I think the way your book really talks about it, is basically a break in that fetal oxygen pathway. That's another way to look at it, okay? It is telling you that your uterus and your placenta are not being perfused properly, okay? So with this, you have this transient hypoxemia, so maybe caused by a contraction, maybe caused by supine hypotension, maybe caused by low blood pressure, okay? You have this chemoreceptor stimulation. So remember, the chemoreceptors are the ones that respond to like the increase in CO2, right? You have that sympathetic reaction. And then the peripheral vasoconstriction, so their blood vessels constrict, which causes their blood pressure to rise. When that happens, the baroreceptors pick it up, and you have vagal outflow, which causes your deceleration. Honestly, this part, it's a little bit harder to understand. The biggest part to understand is late decelerations means something is wrong with that fetal oxygen pathway. Okay, your uterus and your placenta are not being perfused. So what are some causes of late decelerations? Well, honestly, you can look right in the chart in your book to see it. But the big causes that we talk about a lot are maternal supine hypertension, of course, and then that hypertension that's caused by the epidural. You know, we talked about the decreased systemic vascular resistance, that vasodilation that happens in your blood vessels. Other things like placenta previa, placenta abruption is a big one. It's kind of one of the ones that I think the doctors always immediately think about when they see late decelerations. And then everything else, hypertension disorders, anything that's causing a concern with that placenta not working properly can definitely cause late decelerations. It also, one of the things that they mention is that intraamniotic intrapartum infection. So it's also called triple I or chorioamnitis. Those are the many terms you'll hear. And the thing about it is when you have a infection, if you have a uterus that's infected, it's not going to be working properly, and it's not good. Everything is not going to be perfused and oxygenated the way it should be. Okay. Variable decelerations. Okay, so the reason why you need to know the onset to nadir time is because of trying to distinguish between a late deceleration and variable deceleration, early deceleration and variable deceleration. So from the onset to the nadir is less than 30 seconds. A lot of people talk about variables or V's, right? So you see this decrease in the heart rate, and it's a flip of the acceleration. You know how I said accelerations go up 15 beats and last for 15 seconds. This goes down 15 beats and lasts for 15 seconds, but less than 2 minutes, okay? So you can see that V shape. What happens with this? Well, it's caused by cord compression.
So cord compression, your book does talk about it. I don't love their examples, but we'll read them. You know, maternal position where the cord is between the fetus and the maternal pelvis, cord wrapped around the baby's neck, short cord, not in a cord, prolapse cord, all very, very true. The reason why I don't love it is because it also could just be caused by baby playing with a cord. Whatever it is, we know it's cord compression. The cord is being compressed, okay? It's because of the fact that it's an immediate, quick thing that happens, right? So we have that venous compression. Remember that umbilical vein is being compressed. We have relative hypovolemia, okay? So relative hypovolemia with the baby, which increases our fetal heart rate. So at first, our fetal heart rate might increase. And then our arterioles compress. It increases our blood pressure. And again, we have that baroreceptor stimulation, which causes the parasympathetic, which is the vagal outflow. You remember it from the other chart, right? And decreases our cardiac output. So that's actually what decreases our heart rate. So initially you have a sympathetic reaction and then you have a parasympathetic reaction, okay? So when you're looking at a deceleration, you might see the heart rate jump up beforehand, but we're not counting that as an acceleration. We know that I almost think of it like if I'm like drowning or something like that, and I finally am able to get my breath. I'm gonna go, and say I'm still struggling, I get my breath, and then I just can't keep up the fight, right? So it's like they're trying to fight it, and then they're like, I can't anymore, and their heart rate goes back down. So we don't count that as an acceleration. So a prolonged deceleration, simple. It lasts longer than 2 minutes, okay? If it lasts longer than 10 minutes, what is it? It's a baseline change. So more practice, let's see. This looks like 155, moderate variability, and what do we see for the decel? Okay, so looking at this slide, we would look at our baseline first. Our baseline looks like it's about 155, and then what's our variability? Well, our variability looks like it is overall minimal. Maybe parts of it might be moderate. I'd have to really be able to see the strip. Ultimately, if you cannot determine from the screen, sometimes on your computer screen, it can be very difficult. You're really supposed to have the fetal paper strip. Actually, that is what they teach in fetal monitoring classes. You're supposed to only really be evaluating it off the paper strip, but most people do not do that. So looking at it, do we see any accels? We don't see any accels. So you see those little bumps right before the variable and right after the variable. Those would not be considered accelerations, okay? They are that baby going right before it happens. So try to compensate. And then you see that little V. So we have those V's. Those are our variables. We have 2 variables on this slide. Okay, so for this one, first we're going to look at our baseline. That's what we always look at. So first it's 150 for our baseline. And then for our variability, now in that end part, that looks a little bit more minimal, but in the beginning it definitely looks moderate, and we do have 1 accel. So I'd say we could probably be on the safe side and say moderate variability. We would just kind of want to see what our strip continues to look like. So we do have 1 accel, like I said. And then for our decelerations, the nadir of our decel matches up to the peak of the contraction. So these are early decelerations. You see that? So this just shows you with our last slide how the nadir of the decel matches up with the peak of the contraction. So it's really cool. Okay. And I think this might be the last one. So we're looking at what's our baseline. Our baseline looks like 145. What's our variability? It looks like minimal. And do we have any accels? Oh, definitely not. And do we have any decels? We surely do. Looks like we have at least 1 late deceleration right there. Perfect. Okay, and so for this one, we would look at our baseline. So this one's really hard for me to see, but it looks like our baseline is about, say, 150. And then we'd look at our variability. So our variability is definitely minimal. We've got some really smooth parts, but overall, I would say minimal. Yeah, I would say minimal, but I really want to see that strip to make sure it's not absent. Especially, I want to see what happens afterwards. I don't love this strip. And then do we see any accelerations? Definitely not. No accelerations. And then decels, I know it already tells you, but I want you guys to notice. So we see the 3 variables right there, right? The beginning ones, 3 variables. And then that last one is called a late. Now, why do we have a decel that looks probably kind of like a V to a lot of people, right? But it's called a late deceleration. So if you go from the beginning of the deceleration to the lowest point of the decel, it'll be longer than 30 seconds. So remember how I said that's an important number to remember? That's why. Okay. So what this is telling us is this baby is experiencing 1, cord compression from the variables, and 2, uteroplacental insufficiency, uteroplacental perfusion issues, right? So what does that all mean? It means that there's an interruption in our oxygen pathway, bringing it back to the beginning, okay? Our intrauterine resuscitation, and it's going through all of the different types of decels and what you would want to do. And really, you're going to try to target it towards what is going on. The main interventions that you do are changing position. So it says left lateral. We know, and we've talked about, you can turn them left, you can turn them right. So it says it in one section, but not all of them. You can turn them in any position that helps the perfusion for baby. So sometimes left and right, sometimes honestly hands and knees is the most amazing position to get optimal perfusion. Because if you think about it, that uterus is no longer sitting on top of that vena cava and cutting off that blood flow like it needs to be, like it shouldn't be. So if you can just change her position, that's the first intervention. Okay, the second one is fluid bolus. So we would give her an extra fluid bolus, whether it was hypotension because of the epidural, whether she came in and maybe she was very dehydrated. We live in Florida, everybody's dehydrated, especially if they come in the middle of the night. So maybe she needs fluids, she needs a fluid bolus. And then the kind of the last part is that 10 liters O2 non-rebreather. So I'll talk about this in just a second, but O2 is considered our last resort because it is you should think of it more of as a medication. So most people don't think of it that way, but we are a lot more judicious about when we use O2 now in labor and delivery. We didn't always, and we'll talk about that in a sec, okay? So the very first thing is changing position. Now I should say though, if they have Pitocin going, typically your first answer when you see it on an NCLEX of a woman having late decelerations and she's got Pitocin going is to turn off your Pitocin, okay? So this just talks about the oxygen. So you might hear about how oxygen is commonly used during labor. It used to be used a lot more often. Basically, we discovered that we really need a lot more research about the effects of O2 and their benefit, and whether it was causing harm. We don't really know. So in your book, you'll see that it says O2 should only be on for about 15 to 30 minutes. So non-rebreather 10 liters for 15 to 30 minutes. So just kind of tuck that into your head. If you're doing like a fetal monitoring class, we actually teach O2 should never be on while Pitocin is on, but you guys will know that answer already because you'll know that if I'm doing interventions and I have Pitocin going, typically our first line answer is that I need to stop whatever is causing it. And if my Pitocin, if my contractions are causing it, I need to stop causing this harm. Okay, so this is an amnio infusion. So amnio infusion is what we would use if they're having variable decelerations. what you want to think about is that amniotic fluid, that cord kind of floating around in the amniotic fluid is the best for baby. It gives the best blood flow to baby. So when we have either low amniotic fluid or no amniotic fluid, say her membranes have already ruptured, right? We don't have that same nice, wonderful environment for that cord to float around. So we can do an intrauterine pressure catheter, do that internal contraction monitor, and infuse fluid through it into the amniotic cavity. Okay, so that's the reason why we do amnio infusion. Amnio infusion, the concern about it though is that if you're putting fluid in, that fluid needs to come back out. So you need to make sure you're paying attention to the fluid coming back out. And every single facility should have some sort of policy and procedure about how to do it. I'm not going to quote because there's very different information out there. Okay, so fetal heart rate assessment, and I see my video separated this, so I might try to fix that before you guys see this slide. But so fetal heart rate assessment, we actually define it in 3 different categories. So I know that sounds like, oh my gosh, I have to learn 3 categories, but it's actually quite easy, I promise you. So the first thing that I want you to think about, do you remember we talked about how moderate variability is the best, right? So for them to be category 1, they have to have moderate variability. Then they have to have no decelerations, or they can have early decelerations. Remember, early is okay. So normal baseline between 110 and 160, moderate variability, and no decelerations except for the earlies. We're fine with them. Okay. Now, the next category you need to look at is category 3. So 3 is absent variability. Absent. So that's that smooth line that I mentioned I hate seeing, right? With recurrent late decelerations or recurrent variable decelerations or bradycardia. So absent variability and a heart rate of 100 is not good, or a sinusoidal pattern. And so sinusoidal pattern, I know there's a good one in your slides. It's where it undulates and it looks exactly the same. Undulates just like that, looks exactly the same. So when we see those, category 3 is the most concerning. We have to stop the pit. We might end up needing to go back for a C-section or whatever we can do to deliver them as quickly as possible if it doesn't resolve. So ideally it resolves. We resolved it. We somehow perfectly fixed it. Maybe she was having an eclamptic seizure and we managed the seizure and now we have her stable and now baby is starting to look better. So perhaps we fixed it. But really and truly, once you get to absent variability with late decels, once you get to category 3, the idea is get the baby out if we can, if the baby is viable. So those are really those big, heavy decisions that is not an easy thing for us to decide. It's going to be a multi-team effort for sure. So category 2, everything else. Everything, like literally everything. Minimal variability with decels. Absent variability, but no decels. Moderate variability with some decels, category 2. So category 2 is literally everything. So just to review, baseline 110 to 160, moderate variability. We can have some accels, but we don't have to. That's where category 1 and a reassuring NST is totally different. A reactive NST is totally different. And then no late or variable decels. And we don't care about earlies. They're fine. Category 3, absent with lates, absent with variables, absent with bradycardia, or sinusoidal. Now it says for at least 20 minutes. And the reason is because you can have something called pseudo-sinusoidal. Now, I will tell you, AWHONN doesn't really love that term anymore. We're trying to get away from it just because people continue to see sinusoidal and think that it's pseudo-sinusoidal. But really what it is if you have a reason, like say you gave a medication like fentanyl, and then you see the sinusoidal pattern, you only have 20 minutes before it needs to resolve. Otherwise, you have to make some decisions because you're category 3 and that's not good. Category 2 is everything else. So you really only have to remember two, okay? Okay, thank you guys.